Jabbour is Professor of Neurological Surgery at the head of the Division of Neurovascular and Endovascular Neurosurgery in the Department of the Neurological Surgery at the Sidney Kimmel Medical College at the Thomas Jefferson University. He is dually trained vascular neurosurgeon. He performs endovascular and open procedures. Dr. Jabbour is a very active speaker, lecturing on various neurovascular topics and nationally and internationally. He has authored more than 485 papers in peer-reviewed journals, including Stroke, Neurosurgery, Journal of Neurointerventional Surgery, Interventional Neuroradiology, Journal of Neurosurgery, World Neurosurgery, Ophthalmology, and Retina. More than 90 book chapters. Dr. Jabbour serves on the editorial board of Neurosurgery, Lancet Neurology, and the Journal of Neurointerventional Surgery, and many others. He is also associate editor for Clinical Neurology and Neurosurgery. He is the author of 4 comprehensive textbooks. One of them, Neurovascular Surgical Techniques, was translated into multiple language. He has given more than 150 invited lectures nationally and internationally. Dr. Jabbour received a national award for his pioneering of a new technique in the treatment of retinoblastoma in babies. He is the primary investigator on several trials. He is also one of the pioneers in neuroendovascular robotics. Dr. Jabbour is a graduate of the St. Joseph University School of Medicine in Beirut. He completed his residency in neurosurgery at the University of Colorado and Thomas Jefferson University, and his fellowship at Thomas Jefferson University. Dr. Jabbour is past president of the World Association of Lebanese Neurosurgeons, VALN, and he is an active member of the Congress Neurological Surgeons, the American Association of Neurological Surgery, Society of Neurointerventional Surgery, AANS CNS Joint CV Section. He is the course director of yearly conference, the CV Update in Philadelphia. He is also certified level 4 sommelier from National Wine School. Welcome again, Professor. Now you can start your screen share. Thank you.
Thank you. Let me. Okay, can you see my screen?
Yeah, we can see it.
All right, thank you very much. It's a great pleasure and honor for me to be here. Thank you for the invitation. Thank you for your introduction. I really appreciate it. As you know, I'm originally from Lebanon, so Lebanon and Turkey has been really friendly countries. I am less than 1 hour away on a flight from Beirut to Turkey when I used to live in Lebanon, and yeah. So I'm going to be talking about carotid cavernous fistulas today. As you know, this is a topic where mainly the treatment has been recently, in the last 10 years, mainly endovascular, and those are my disclosures. None are related to what I'm going to be talking about. So we're going to be talking about this anatomical region today. As you saw, you know, the cavernous sinus, where you're going to have your carotid, and when you're going to have a lot of nerves going in through that. So the etiology of carotid cavernous fistulas are mainly traumatic. 75% of all carotid cavernous fistulas are traumatic. When it's traumatic, it's a type A. We're going to talk about the types. And 0.2% of patients with craniocerebral trauma will have a carotid cavernous fistula associated. 4% of patients with a basilar skull fracture will have a carotid cavernous fistula. The majority of those are direct fistulas, are type A. It means direct communication between the internal carotid artery to the cavernous sinus, direct opening. And so the etiology of carotid cavernous fistulas will be spontaneous in the rest of the cases. So we said 75% are traumatic. So around 30% of the rest of the fistulas are spontaneous fistulas, mainly found in older female. When it's a ruptured cavernous aneurysm, this is a direct fistula. When it's spontaneous, a lot of times you'll find, some history of FMD, Ehlers-Danlos, or any collagen disease. What can predispose you to a carotid cavernous fistula? Some stress, a lot of coughing, Valsalva. And there's a theory of the microscopic venous thrombosis, increase in the sinus pressure, and microscopic breaks in the dural vessels. Same theory of the regular dural arteriovenous fistulas that we see mainly in the transverse sinus. The Barrow classification, this is the most common classification that's used for carotid cavernous fistulas. You have the type A, which is the high flow, which is the fistula supplied directly from the internal carotid. This is when you have an injury to the internal carotid. That's why it's mainly in traumatic causes. And in ruptured cavernous aneurysms, this would create a type A CC fistula. Those are aggressive fistulas. If left untreated, they're gonna all go toward blindness because of the really severe type and high pressure type. Then you have the type B, which is the supply of multiple small meningeal branches of the internal carotid artery. Type C is the supply from the meningeal branches of the external carotid artery. And type D is the combined form with the B and C. The most common type, other than the type A, other than the direct, the most common type of flow is a type D, which is a combined B and C. Those are the fistulas I talked about. So this is the direct communication, type A. You have a meningeal branches, which is type B. Then you have the type C, which is meningeal branches of the external, and the combined branch, which is the type D. The clinical presentation, we all know, so the high flow would present acutely after a trauma. You have a really dramatic proptosis, chemosis, orbital bruit, pulsatile proptosis, headaches, orbital pain, and then the cranial nerve deficits are mainly diplopia, oculomotor deficits. And then rarely it can present with a subarachnoid hemorrhage and intercerebral hemorrhage. This is in cases where the drainage pattern is mainly posterior, causing cortical venous drainage, exactly like when we're talking about regular dural arteriovenous fistulas, where when they are borderline high grade or Cognard high grade, they have cortical venous drainage and they tend to present with hemorrhage. Same with the CC fistulas. They can either drain anteriorly toward the eye, which would affect the eye, or a combination of anterior and posterior. When it's posterior, it's gonna present sometimes with a hemorrhage, but rarely. With the low flow indirect fistulas, it can have the same symptoms, but the symptoms onset would be more progressive. You're gonna have those patients that have been around so many ophthalmologists over 3 to 6 months, where they tried so many eye drops on them, where they diagnosed them with conjunctivitis, did so many things, and at the end, they said, oh, this may be a CC fistula. Imaging, as you know, the gold standard is the cerebral angiogram, and it's mainly, it should be 6 vessels, not 4 vessels. So you need to super select catheterize external, internal, both sides and verts. And this is how you're gonna diagnose the fistula and mainly classify the type. MRI, MRA will show sometimes engorged cavernous sinus, enlarged oculomotor muscles because of the edema, enlarged superior ophthalmic vein, or a proptotic eye on MRI. CTA, same thing, will show an enlarged SOV, enlarged cortical veins sometimes, and then sometimes a blush of the cavernous sinus, but it's not very, very sensitive. And then color orbital Doppler is the less common invasive procedure, which is really a Doppler that the ophthalmologist would use in the eye. And this is interesting because this is really can diagnose the fistula before any imaging and or anything. I'm going to talk to you about it in a little bit. So the CTA will show, this is rarely you will have a nice picture like this, right? Usually you won't, and it won't, it would be really not giving you those pictures. So, but when it's when you're gonna have an abnormality, it's gonna be something like that, and those are the SOVs. MRI, same thing. You're gonna have some, you know, enhancement of the cavernous sinus. You're gonna see like an SOV, like you see here on the left. And then the orbital color Doppler is important, something that any eye doctor would have in his office or in the eye emergency room. which is we looked at and compared different in this paper that we've published maybe less than 10 years ago, compared the color Doppler to CAT scan to MRI, and you see that sensitivity wise it has the highest sensitivity to diagnose a fistula, 96.8%. The negative likelihood is really low. And when we say negative likelihood, what does this mean, those numbers? Well, those numbers means whenever it's so low, if you look here, it means large and often conclusive decrease of the likelihood of a disease. It means when I tell you the negative likelihood is 0.080%, this is pretty good. It means if the Doppler is negative, it means really less likely that the patient's gonna have a fistula. Specificity is not so much there, but more sensitivity. And then what would you find on the color Doppler? You will find an arterial waveform. In 83.7% of the times, you'll find an enlarged SOV in close to 80%. And this is really important, reversal of flow. Whenever you look and you see a reversal of flow, it means this is a color Doppler. You're gonna see the arterial in red, the venous in blue. So you can see the direction of flow. So when you have on the in the veins a reversal of flow, it means the veins flow is flowing toward you, toward the eye, instead of flowing back away toward the cavernous sinus. This is really high sensitivity and specificity. So what are the indication to treat? So in the direct high flow fistula, that's the indication to treat, regardless if there are symptoms or not. This is a direct high flow fistula. It means if we don't do anything, this patient's gonna go to blindness quickly. In the indirect low flow fistula, indication to treat if there's cortical venous drainage. In what would make of it an emergency? It's the IOPs, and this is very important. You need to check the IOPs. If the IOPs are high, sometimes we have IOPs 80 or 90 or 100. This is an emergency because if you don't act on that, the patient's gonna go blind. The IOPs are usually high all the time in direct fistulas. In indirect, sometimes they are high, sometimes they are moderately high. If they are 20 to 30, the eye doctor can give some eye drops to decrease them, and this wouldn't be a real emergency. Other indication to treat: headaches, retroorbital pain, diplopia, proptosis, chemosis. Again, sometimes it's a quality of life if the patient has a disabling bruit, where if you take your stethoscope and you put it on the globe, you can hear this bruit. Treatment-wise, we'll start with the less invasive, the simplest one, but unfortunately it doesn't work much, which is the, as I said here, is the cheapest, which is the intermittent carotid compression. This works only in some of the low flow indirect fistulas, where you would teach the patient to put pressure on the carotid for 10 seconds, 6 to 15 times per day for 6 weeks. Some warning here: you need to make sure the patient doesn't have carotid disease, right? If the patient has carotid atherosclerotic disease, you don't want the patient to be pushing on that and causing any thromboembolic event. Very important to teach the patient to do the compression contralateral with the contralateral hand. Why not with the ipsilateral hand? Because if you go with the ipsilateral hand, you can push and sometimes you can decrease the flow, and it will affect the left-sided hand who you're not using, and sometimes this can cause a TIA or a stroke. If you use the contralateral hand, I'm doing this. If this is gonna cause a TIA or a stroke, it's gonna affect my hand I'm using, it's gonna drop, it will reestablish flow. So for security reason, contralateral hand. And then this works in around less than 1/3 of the times of the low flow fistulas, which is not very efficacious. If we're gonna talk about a treatment of carotid cavernous fistulas, remember, this is a venous disease. It means you need to be on the venous side. Other than the high flow, which I'm gonna show you later on how we're gonna treat the high flow, which you're gonna go through the artery to the vein, all the rest of the fistulas, you need the main goal to treat, you need to reach the cavernous sinus. You need to reach the venous side. How are you going to reach the venous side? If you see here the schematic, this is your cavernous sinus. There are multiple ways for you to reach the cavernous sinus. You can either go from your IJ, and then from the IJ go from the IPS, inferior petrosal sinus, and then you're gonna be in the cavernous. Superior petrosal sinus usually is more difficult. It's rarely present and it's very small. So from an endovascular standpoint, you'll have a higher chance of going through the IPS as compared to the SPS. So this is one way, IPS. So you would go IJ, IPS with your microcatheter. Another way of going there is to go through your superior ophthalmic vein. And this, you have an anastomosis with the facial vein. So if you go from the internal jugular vein, you go in the facial vein. The facial vein usually hooks in the internal jugular vein. And then you go from the facial vein, you go through the anastomosis of the superior ophthalmic vein. Then it's a straight shot to the cavernous sinus. I'll show you a case like this. Then if all those, you can't go through any of those, at that time, you'll go more invasive and you'll go through the superior ophthalmic vein. When it's the case, you need to go in and catheterize the superior ophthalmic vein. You can do it either with open exposure, this is what we do here. We do a small cut above the eye, and then we expose the vein, and then we catheterize the vein. Another way of doing it is a direct puncture, which is a little bit higher risk in case you puncture it and you don't get it at that time. Remember, this is not venous blood, this is arterialized veins. It means you may have a big hematoma. And one last option is direct puncture of the cavernous sinus through the superior orbital fissure. And in this cases, you go with a needle and you puncture the cavernous sinus. Again, the risk here is a retroorbital, retrobulbar hematoma. This can cause blindness. It can really progress quickly because those are arterialized veins. We don't do that because we feel that the exposure of the superior ophthalmic vein with open surgery is much safer, but there are some centers that would do that. So those are the different ways of reaching the cavernous sinus. Another way is depending on where the drainage is. I'm going to show you cases where the drainage was mainly in the superficial sylvian veins, where we went through that. I'll show you the case. Open surgical treatment, I'm going to say this is historical because with all the endovascular armamentarium that we have, we rarely have to go open surgery. And what would be the open surgical option? It would be to go in and pack the cavernous sinus with muscle or inject some fibrin glue in the cavernous sinus. Again, this with the endovascular techniques, there's no role for that. I put the picture here of the king of the cavernous sinus surgery, which is Vinko Dolenk, as you know, the king of operating in the cavernous sinus. And historically, another open surgical way, really long time ago, was the slowly internal or common carotid artery ligation. I don't know if you're familiar with what I'm showing here. This is the Silverstone clamp, where they would do a cut above the carotid, put this clamp, and every day turn one notch. And what this does is close the carotid slowly and let the collaterals form. Again, we don't do this anymore. This is a historical perspective. And at this point, as you can imagine, what happens is you would turn slowly the clamp every day. There would be flow. And what happens is the last day where you turn the clamp completely and the carotid would shut down, this is when a lot of patients would really have a stroke. So endovascular techniques for mainly the type A, the direct, it's mainly transarterial because you have a hole between the internal carotid artery and the cavernous carotid artery. And you can use it with or without a balloon. I will show you some cases. For the transvenous type B, C, and D, you need to go transvenous to the cavernous sinus. You can go either through the IJ, inferior petrosal sinus, cavernous sinus, or you can go IJ, facial vein, SOV, cavernous sinus. You can go directly, or you can go direct puncture, as I said. I'll show you some cases. So those are little bit different ways. This is a direct carotid-cavernous fistula, direct communication. Long time ago, we used to have detachable balloons where you would go and detach a balloon. Those don't exist anymore. This is another way showing you some coils. You can go in through that and put coils. And this is showing like a covered stent or coronary stents, which we don't use because we have the better ways of doing it. In the transarterial way, we're gonna go mainly with a balloon to inflate a balloon in the carotid to protect it from any reflux of any coils or liquid embolic in the carotid. This is a case of 23-year-old patient with Ehlers-Danlos disease, was being followed for multiple brain aneurysms. One of them was a large cavernous aneurysm, presented with a sudden retroorbital pain, bruit, proptosis, chemosis. This lady had a direct fistula. In those cases, as I'm showing you here, I'm gonna go back. So here, as if I'm injecting, you know, I'm on the venous side, I'm showing you a venogram. Well, this is not a venogram. This is an angiogram arterially. I am doing an internal carotid run. What happens is, that's the internal carotid, and then it's all dumping blood on the venous side in the cavernous sinus. There's a shunting of blood completely, so you don't even see intracranial vessels. Why? Because there's a steal phenomenon, and all the blood of flow is going into the venous side. That's why we're doing an internal carotid injection. All you see is cortical venous drainage and SOV and cavernous sinus. So this is really severe. This is an AP run showing you that all the cavernous sinus, you don't even see intracranial vessels because of the shunting of blood, how high the flow is. And this is a microcatheter and a balloon. I'm going here through the hole from the internal carotid artery. I found the hole and I'm going through the hole. As you see, I'm inflating the balloon inside the internal carotid. I have another catheter in the cavernous sinus, and this I would protect the internal carotid when I'm gonna start putting my coils, deploying them in the cavernous sinus and injecting liquid embolic, which is onyx. It will prevent reflux in the internal carotid. And this is a super selective injection in the cavernous sinus, confirming that my microcatheter is in the cavernous sinus. And those are some coils. At that time, this was a long time ago, I used to still use coils. Now I don't use coils anymore. I use liquid embolic. It's faster. It goes all in the septation of the cavernous sinus, and it does the job better than the coils. As you see here, the coils are being deployed in the other compartment of the cavernous sinus. This is the internal carotid artery. Then through the hole, I went out in the cavernous sinus, and I'm deploying my coils. And this is my liquid embolic. I'm injecting onyx that goes all the way to shut down everything. And as you see the onyx here being injected, I have my internal carotid artery protected with a balloon to prevent any reflux. Again, on another view, you see the onyx going all the way in the cavernous sinus. And this is the run at the end, as you see in my run. So now I can see intracranial vessels because I shut down the flow, the shunting. Now I can see the intracranial vessels. This is just some disease from her Ehlers-Danlos. She has all kind of pseudoaneurysms at the neck. This is a case of a patient that presented with a gunshot wound to the face. The patient was bleeding from the external carotid, and the patient had a really proptotic chemotic eye with pulsatile proptosis. The patient had both external carotid artery injuries and a severe type ACC fistula. I was able to go first in the external carotid branches to shut them down because this was a carotid blowout that brought the patient where they had a compression on the face because the patient was bleeding to the outside. So this is here, I'm injecting onyx in the external carotid. This is the internal carotid showing the same, everything going in the cavernous sinus. And as you see here, I'm injecting onyx in the cavernous sinus. That's my balloon being inflated to protect. And this is my onyx being injected in the cavernous sinus. This is the run. Now you can see the intracranial vessels, lateral view, because we shut down the fistula. This is the balloon. You see the fragments of bullets there because this was a gunshot wound. You see the cast of onyx in the cavernous sinus. Another case of a type A CC fistula, you see same thing. You see I'm going, but in this case, I went from the IPS all the way up to the cavernous sinus. and then inflated the balloon in the ICA to protect it, injecting in the cavernous sinus to confirm I'm in the cavernous sinus, then injecting the onyx in the cavernous sinus. Same thing, that's a run showing that now you have all intracranial vessels open. Again, another traumatic MVA showing the same thing, the onyx after. And then we have published this, the use of the balloon assistance, and this is described our technique of inflating the balloon in the carotid to protect from any reflux. This is the case of a CC fistula type A caused by a ruptured giant cavernous aneurysm. You see here the SOV is huge. You see the opacification of the cavernous sinus. Here, I decided to treat it with stent as a pipeline-assisted coiling, transradial approach. You see here, that's a 3D showing that cavernous aneurysm. This is my transradial approach. And then I'm going in, that's my pipeline that I deployed. And then I'm gonna coil the cavernous aneurysm. And this is my final run, showing the complete occlusion of the carotid-cavernous fistula by occluding the aneurysm and having a durable treatment with the pipeline. The pipeline would seal everything because those large giant cavernous aneurysms have a high recurrence rate with coiling. We talked about this with a paper on off-label use of pipeline, where we talked about treating some carotid-cavernous fistulas that are caused by a ruptured cavernous aneurysm with that. Let's talk about carotid cavernous fistulas treated transvenously. I'm gonna start with this case where you see here the CC fistula on the AP. This is a lateral run showing the early opacification of the cavernous sinus and the dilated SOV there. Here I'm going transvenous. This is the IJ. I'm in the IJ. That's my microcatheter. I'm trying to catheterize the inferior petrosal sinus, where a lot of times it's blind. And this is my microcatheter going. I'm going up toward the cavernous sinus. This is another view showing my microcatheter being advanced all the way to the cavernous sinus from the IPS. That's the IPS. And this is a super selective injection of my microcatheter after I parked it in the cavernous sinus. As you see here, you see the cavernous sinus and you see the retrograde filling in the SOV. That's the SOV, that's the orbit, that's the IOV, inferior ophthalmic vein. So you see here how this is supposed to be the other way. This is supposed to drain from the eye to the cavernous sinus to the IPS to the IJ. But here you see it how it's draining the contrary on the other side, retrograde. And here with my catheter, I'm injecting onyx. Something very important, it's very important to make sure you're not having reflux in the SOV too much. It's okay to shut down one of them. If you shut down the SOV, you keep the IOV open. If you shut down the IOV, keep the SOV open. If it happens that your liquid embolic goes and shut down both, high chance of the patient, you will cure the fistula, but the patient will have a spike of IOP, intraocular pressure, the first 24 hours to the 70s, 80s. In those cases, you need to go in bedside and do a canthotomy to release pressure. Otherwise, the patient can lose the eye. It takes at least 24 hours for the blood drainage of the orbit to find their way. So the main risk of spike is the first 24 hours. If you take care of it with canthotomies, the next 24 hours, everything will calm down. This is post-embolization. You see complete occlusion of the CC fistula. This is another case about the transvenous embolization of a type D fistula, where we went through the facial vein. So we went through the IJ, facial vein, SOV, cavernous sinus. I'll show you.
The following is a case present.
The movie, let me bring this down. Okay. I'm gonna go quickly. So you see here the early opacification of the cavernous sinus. But on the lateral view, you're gonna see the facial vein being opacified. Here it is. That's the supraophthalmic vein. That's the facial vein. again, that's the cavernous sinus, early opacification. And lateral view, SOV, IOV. It's cut a little bit. That's the facial vein going down. As you see it, it's anastomosis. It's anastomosis with the SOV. Now you will see it better. You see the anastomosis. You see the facial vein all the way hooked in the cavern in the IJ. So I went through the internal jugular vein, catheterized the facial vein, and here with my microcatheter, I'm trying to make the turn on the anastomosis between the facial vein and the superior ophthalmic vein all the way to the cavernous sinus. Sometimes this bend can be a little bit tricky. And here it is, you see, I'm all the way in the cavernous sinus with my wire. I'm gonna advance my microcatheter over the micro wire all the way to my cavernous sinus. This is the super selective injection in the cavernous sinus. You see the IOV, the SOV. And after that, I'm gonna start injecting my liquid embolic. Here is my onyx, my liquid embolic being injected, going through the septation of the cavernous sinus. All the way. This is a run showing complete occlusion of the carotid-cavernous fistula. We don't see any early filling of the cavernous sinus anymore. This is an AP view showing the complete occlusion. This is the cast of onyx that you'll see there in the cavernous sinus. So, as you know, more and more, I'm one of the biggest users of transradial approach in neuroendovascular for the last 3 years. And now we're even going transvenous. When we're gonna go transvenous, we're also going through the arm, not the groin anymore. This is, I'm using the cephalic vein. So this is the case showing here the transradial approach arterial here, and then up above, we catheterize the cephalic vein, then we go all the way cephalic vein, subclavian vein, IVC, is SVC, and then you'll go to your IJ. This is the collaboration that we published about doing the transvenous approach all from the superior, so from the upper extremity. And as you see here, all the areas, anatomical areas where you can catheterize the veins to go transvenous. The majority, I use the cephalic vein here. Supra-ophthalmic, superior ophthalmic vein approach, when do you use that? When you cannot use any endovascular approaches to the cavernous sinus and you have a SOV that's dilated, you don't have any other option. At that time, we'll go through that. At that time, we'll do a cut above the eyelid. We find the SOV, we catheterize it. As I said earlier, be careful of occluding both SOV and IOV because of the high risk of spike in IOPs. This is a case of a CC fistula type D. You see on the lateral view the dilated SOV. We couldn't go any transvenous approach. Our only way was to go SOV. What we did is the SOV approach in the hybrid room, cut above the eyelid, expose the vein. That's the SOV that we've exposed. We have it here. Here it is. And I put an angiocath in the SOV with everything. This is my catheter on the lateral view, going all the way. This is when I was still using coils. And this is all occluded. And here it is. So the SOV, we've described this long time ago. This is really one of the earliest paper on our earliest experience on SOV and using onyx. This is what we're doing, exposing the SOV here, going all the way. As you see here, the facial vein, the SOV, we catheterize it all the way to the cavernous sinus. This is an example of patients, for example, presenting with the CC fistula before and after. This is 4 weeks after surgery. She had an SOV. The wound healed nicely, and the eye is much better. Again, not always it's a CC fistula. This is an unusual case actually of an ethmoidal arteriovenous fistula draining into the SOV directly without draining into the cavernous sinus. But the patient presented as if the patient has a CC fistula because the patient presented with a proptotic chemotic eye. We thought the patient had a CC fistula. Turned out the patient had this fistula carotid to SOV only, no opacification of the cavernous sinus. So we went in SOV approach and we shut down the fistula, and the patient did well. We published it as a technical case. This is another case, 50-year-old female, presented with proptosis chemosis, double vision for the last month, treated with eye drops for 2 months. As I told you, those patients would go, they think they have conjunctivitis, and the patient present with a right-sided third and sixth nerve palsies, angio done at an outside hospital. Here it is, you see it. They tried to embolize transarterially. You see the CC fistula from the external run, the lateral view of the external run, lateral view of the internal. So this is a type D. It has a combined external and internal. This is the left ECA, AP. You see here, you have the cavernous sinus opacification, but then the drainage, if you look at it, is going where on the AP? All the way to the superficial sylvian veins. If you look on the lateral view, I don't see any SOV, so either no SOV drainage or SOVs are thrombosed. So in this case, we need to find a way to reach the cavernous sinus. You see it here, all the way to the superficial sylvian veins. So what we did is, how are we gonna treat this patient? No transarterial option. In those type D, this patient went to an outside hospital. They injected a little bit in the external feeders. You can never treat those from the arterial side, very rarely. If it's not a type A, a type B, you cannot. Transvenous, we couldn't go IJ, IPS, we couldn't go SOV. We don't like to do direct cavernous sinus puncture. So what we did is, so this is showing you what not to do. This was done at an outside hospital. They injected proximally from the arterial side, didn't do anything. So what we did is we went try IJ, but we couldn't find any patent IPS. So we decided to go and catheterize the superficial sylvian veins to go to the cavernous sinus. How are we gonna do this? Well, it's a hybrid approach. I did a burr hole, image-guided burr hole on top of the sylvian veins. Those are the sylvian veins. And then this is what I did, a small burr hole. And those are the veins. Those are the arterial veins, the sylvian veins. And then I catheterized the veins with this angiocath. And this took me directly to the cavernous sinus because the drainage was directly in the sylvian veins. So as you see here, I'm doing it in the hybrid rooms. And here it is, I'm advancing my microcatheters, looking at the screens. And as you see here, that's my microcatheter going all the way to the cavernous sinus. And then this is my angiocath in the superficial sylvian vein. And here it is, I'm injecting liquid embolic onyx all the way to shut it down. Here it is, now completely occluded. I'm removing my microcatheter, and here all I need to do is put a gel foam with 5 minutes of pressure on the superficial sylvian vein, and then a burr hole cover. It will take care of it, and this is how we were able to cure it. We published it as a technical note of a hybrid technique, combined open and endovascular technique. This is a case of a CC fistula with cortical venous drainage. As you see here, that's the fistula, a lot of cortical venous drainage. Here, the facial vein. So in this case, we were able to get through the SOV, but what you see here, that's why I always do a super selective injection from the cavernous sinus. This drainage is all the way always up in the sylvian veins. So the problem here, if I'm gonna inject onyx, the onyx is gonna fly to the cortical venous drainage and cause a venous infarct. So in this case, I decided to use coils. So always keep in mind that coils, we still use them, but in like cases like this, where you don't want your liquid embolic to fly in the cortical venous drainage and cause a venous infarct. So that's what I did. Carotid cavernous fistulas presenting with an intracerebral hemorrhage, it's very rare. This is when you have a carotid cavernous fistula draining mainly posteriorly, not anteriorly. This is a case where a patient presented with a intracerebral hemorrhage. We did an angiogram showing that the patient has a CC fistula, and you see there's a cortical venous drainage to the left side in the superficial sylvian veins. And that's what caused the hemorrhage, and we were able to treat that. But remember, it's very rare, but it can happen, CC fistula presenting with a hemorrhage. So a lot of times they, a lot of endovascular colleagues say, well, you're injecting a lot of liquid embolic in the cavernous sinus. You're not causing more oculomotor problems. So we looked at our series and the onyx embolization and the impact on intraocular pressure and recurrence in those cases that we've published, around 42 cases of carotid cavernous fistulas treated with onyx. So as compared to coiling, so those are the types of fistulas and what we treated. And this is the new symptoms after embolization. So percentage of immediate postoperative new symptoms. Cranial nerve palsies, we have in 30% of the times, you have new symptoms, new cranial nerve palsies. But around 80% of them would resolve at the last follow-up, which is at 3 months. So the majority of them would resolve. Proptosis, 2%, 100% resolved at 3 months. Chemosis, same thing. Those are, I'm talking about new symptoms, complications after embolization. Decreased visual acuity, 9% of the times, resolved 70% of the times. Headaches, same thing. So this is showing the symptoms improvement after and the resolution after liquid embolic. You see it in type A, B, and C. You see the more symptoms resolution in the type A, to be expected, and the associated decrease of the intraocular pressure in the type A, B, C, D, all the way after treatment. Sometimes you have to inject a lot of liquid embolic. This is an onyx cast. A lot of times it looks like that. And I think at this point, the diagnosis of CC fistula requires a high index of suspicion. A delay in treatment may lead to irreversible damage. A lot of times we see those cases, those patients that, as I said, for 2-3 months going around with eye drops being treated for infection. Angiography remains the gold standard for diagnosis. We have a preliminary way of diagnosing it, as I said, with screening with the color Doppler. The endovascular approach is the first-line treatment, giving the low complication rate and the favorable long-term outcome. And we can use liquid embolic safely. A lot of times this fistula may require multiple agent and multiple treatment. So onyx is safe, cure rate above 95%. It's a collaboration with ophthalmologist, and it should be a tailored procedure. Very important to follow the IOP's intraocular pressure the first 48 hours to avoid any dramatic increase in IOPs and loss of vision the first 24 hours. Thank you very much. And this is all I wanted to.
Thank you, Professor. It was excellent presentation.
Thank you.
Firstly, I want to ask one question. We see on emergency room a lot of intracerebral hematomes. Maybe some of them have Carotid-Cavernous fistulas. When we suspect for them for CCF pathologies.
So again, this is not just talking about CC fistula causing a brain hemorrhage, because this is rare. it's mainly when do we think that the intercerebral hemorrhage, there is an underlying vascular cause of that, which could be an AVM, a dural AV fistula, or sometimes a CC fistula, mainly in young patients with no risk factors, where with the pattern of the hemorrhage, it's not like a basal ganglia hemorrhage, a typical high blood pressure hemorrhage, where those patients are young with no risk factors. We are aggressive looking for an underlying lesion. Now, in those cases, you'll have a higher chance of finding something else other than the CC fistula. But when you do the workup, you're gonna find anything, which in some cases CC fistula. So I'm gonna say it's rare to have that, but while you're doing the workup for other reasons, you're gonna diagnose your CC fistula.
Thank you, Professor. There is another question from Professor Yunus Aydın. He say, as far as I understood, that Dr. Jabbour is hybrid endovascular specialist, which is the ideal for my opinion also. Could he tell us his opinion about hybrid endovascular specialty?
I can talk for hours on that topic, and I always, I have a lot of lectures talking about encouraging people to be hybrid. I think at this day and age, to be able to be a vascular neurosurgeon, you need to be a complete vascular neurosurgeon. By saying complete, it means you need to be able to be familiar with all the techniques, because you need to be able to treat the disease itself, and you shouldn't be procedure oriented or device oriented. We should all be disease oriented. And at this point, all the young people going through a specialization and residency, I encourage them really to, if they want to be in the vascular specialty, they need to be trained in both. And I think doing only open or only endovascular, that's not the best choice. Now, if you don't have a choice, at that time, you really need to have an interventional neuroradiologist or interventional neurologist that you trust, where it's really a collaborative work and not a competition, not trying to really each side trying to keep the patients. And it's very important not to fall in the idea of, well, if my tool is a hammer, everything else is a nail, where I need to use my tool regardless. It's very important to be objective in choosing for the patient and choose what's best for the patient, even if you have to refer the patient to somebody else because you don't have the knowledge or the capability of doing the technique. So, yeah.
Thank you, Professor. There is another question too. From Fatih Yakar. Dear Professor, CT and DSA negative LP positive subarachnoid hemorrhage is possible for a type B CSF. Do you have any experience on this station?
Subarachnoid hemorrhage is, well, when you're gonna do, I mean, if it's a type B, you're gonna find it on the angiogram. So the angiogram won't be negative. So if you have a subarachnoid hemorrhage and you did the workup, you did an angiogram, you're going to diagnose the type B fistula. At that time, if you don't have any other cause, if you don't find any aneurysms, you don't find any other reasons, and you find the type B fistula, yes, that's the cause of the subarachnoid, and you need to treat it.
Thank you. A question from Ismail Akgol. What percentage needs hybrid surgery for CCF treatment in your experience?
Very rare. The majority of them will need only endovascular. Like I showed you my series, I'd say in the last 10 years, I had to do this burr hole I showed you in only 2 cases. So very rare. 99% of them will be treated only endovascularly.
Thank you. A question from Fatih Yakar. Is flow diverter deployment for type B CCF feasible? Sylvian vein catheterization was spectacular. Professor, how did you fix the needle in the vein?
Okay, so for flow diverter and carotid-cavernous fistula, the only time I would use it is when the carotid-cavernous fistula is caused by a ruptured cavernous aneurysm. In this case, you're gonna coil the aneurysm and use the flow diverter for a durable treatment. But in general, having any type of fistula, like a type B fistula, going up and placing a flow diverter, I would not do that because of the problem of gradient of pressure. Remember, when you use a flow diverter on an aneurysm, the aneurysm is a pouch. There's no big gradient of pressure. You cause stasis, it will go away. When you have a fistula, it's a lesion that's continuously sucking blood and the gradient of pressure. So the pipeline enough or a flow diverter is not enough to close that fistula because you still have this gradient of pressure. That's why I would not do that. Now, the Sylvian Frey catheterization, yeah, thanks. How do you fix the needle in the vein? Good question. As I showed you, it was a small angiocath. All I needed to do is I took a gel foam and then I placed it on the puncture site, put a small quarter by quarter patty, cottonoid, and put pressure for like 5 minutes, and then irrigated, and then left the gel foam on it, didn't bleed. Then I put the burr hole cover on it and put pressure, and that's how I closed it.
Thank you, Professor. I don't see any more questions. Maybe it was excellent presentation. No need more questions. Thank you again. Lastly, Associate Professor Suju, do you say anything about the lecture?
Yeah, Dr. Pascal gave an excellent lecture. He shared his experiences in detail. We were lucky today. Thank you again so much, Dr. Pascal.
Thank you so much, efendim.
Teşekkür ederiz.
Thank you.
Okay, we can enter. Also, we want to be your guest in Turkey.
I would love to.
Your guide in Turkey. Did you come ever?
Absolutely. I've been to Turkey maybe before COVID, 4 or 5 years ago, many times, but not recently. But it's a great country. I love it, and I would love to go back.
Have you been to İzmir before?
No, not İzmir. Only Istanbul and Ankara, but not İzmir.
Maybe this time.
Yeah.
You can come to İzmir.
Yeah.
Okay. See you.
All right. Thank you, guys.
Thank
Bye.
you very much.
Thank you too.
Bye-bye.